Obsessive-compulsive spectrum disorders. So among the obsessive-compulsive spectrum disorders, the most common is obsessive-compulsive disorder itself, that is called OCD. Then you have body dysmorphic disorders, hoarding disorder, trichotillomania or hair pulling disorders, then excoriation disorders. Okay, so let us start with OCD itself. It is the most common disorder that we have seen. And what are obsessions? Let us read the slide first, and then I'll explain it to you. Obsessions are repetitive, persistent thoughts, images, and urges. Repetitive here means, see, your generation probably hasn't seen those audio cassettes. So when the audio cassettes used to get stuck, the same loop of a few words used to get repeated again and again, like a loop almost. This is what is repetition in obsessions. They can be either thoughts, they can be either images or even urges or impulses. So the characteristics of obsessions are, they are recognized as one zone. Repetitive, again, bar, 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 ana. Senseless or illogical. Intrusive. Okay, what does intrusive mean? So long time back when we had the Kargil war, so it was said that intruders have landed in across the border. So intrusion means somebody is entering without my permission in my territory. That is what is intrusion. These thoughts then lead to anxiety or distress, and attempts to ignore or suppress them, that is by performing a compulsion, usually does not help. So how does the patient present to you? Let us take the most common obsession, that is obsessive doubts of contamination. In this, the patient will tell you, I feel that the doorknob I am touching is dirty. He recognizes this as his own thoughts. He will say, yes, these are my thoughts. मेरे अपने विचार हैं, ये बार बार चलते रहते हैं. I know they are senseless, they are illogical. I try to control them. I feel a lot of anxiety, and I ultimately have to go back and wash my hands. Once I wash my hands, what would normally a person think? Okay, now my hands are washed. Now there is no chance of it being dirty. But a person who has an obsession, this thought will again come, making him wash his hands again, and this loop can go on multiple times, leading to a lot of distress and dysfunction. Okay, now let us see what is a compulsion. Compulsion is a repetitive behavior or mental act in which the individual feels that he needs to perform a behavior in response to an obsession or according to the rules that can be applied rigidly. They are aimed at reducing or preventing anxiety or distress towards some dreaded event or situation. However, these behaviors are not connected in a realistic way to the feared situation. So when does it begin? Obsessive compulsive disorder usually begins sometimes before the age of 10, usually in teenage or even early adulthood. In men, early onset is more common. Cleaning compulsion. In women, the onset is later, and the course is usually a chronic course. Prevalence is about 1 to 2%. If untreated, the course is chronic, we have already said, and sometimes you often have an episodic course, and minority also has a deteriorating course. So functional consequence would be that impairment is caused by time spent in obsessions and doing the compulsions. Avoidance leads to severe restrictions in functioning, derails time completion of work, dermatological problems, imposing rule on family members, leading to family disruption. So the functional consequences of OCD are actually very serious. Sometimes a person will spend hours in the bathroom washing his hands or washing himself or having a bath. There are people who come and tell me that this person spends almost 8 to 9 hours in the bathroom performing the compulsions, in case the obsession is obsession related to dirt, which I have told you is one of the most common obsessions. Sometimes it goes on to the family members also. They will tell family members also that you also need to wash your hands in a particular way. One attempt of washing hands may take 15-20 minutes, and imagine a person who is washing hands so much, what will happen to the condition of his skin? They develop eczema, dermatological issues. So OCD cycles. See, let us see what happens here. There are obsessions. It could be urges, mental images, It could be anything, leads to anxiety. Then person performs the compulsion. Let us say the example of washing hands. He will wash the hands thinking that there will be relief. But what happens? The relief is only temporary. The obsession will come back again. As I've told you, it is repetitive, like a loop which has got stuck, which will again lead to these obsessions. So the person actually gets caught up in this, this vicious cycle, that I would like to call it. So again, let us see type of obsessions. There are numerous types of obsessions. Contamination are the most common. Contamination obsessions में होते हैं doubt of contamination या dirt. वो dirt हो सकता है, germs हो सकता है, bacteria, virus, कुछ भी हो सकता है. So there'll be a doubt कि ये गंदा है. अब या तो इसको साफ करो, or if I touch it, I will have to wash my hands, probably take a bath, maybe clean up the entire room. So let us read what is written in the slide. Contamination obsessions may have concern with dirt or germs, concern with bodily waste like urine, feces, or saliva, concern with environmental contaminants, radiation, with household items like cleansers, solvents, pets, concerned that they will become ill. There are certain aggressive obsessions also. Aggressive obsessions will be fear of harming others. See, these are also thoughts which are going on, repeating themselves. Fear might harm self. There can be violent images. There is fear of blurting out insults. There is fear of blurting out certain wrong words, fear of blurting out certain words towards gods, which is also known as blasphemous obsessions. Fifth point, doing something embarrassing, something terrible may happen. See, something terrible may happen, and fear that that I may harm others usually happens in these other fears which are usually there in childhood. These are the obsessive doubts or the obsessive thoughts usually seen in children. If a child develops OCDs, these are the most common things which are seen. Acting on impulses. Then there can be sexual obsessions, which are again very distressing, forbidden or perverse sexual thoughts, images, or impulses. Content may involve children, animals, incestual activity, even homosexuality, because all these thoughts are again repetitive, intrusive. Patient realizes they are senseless, so they invoke a lot of distress. Then there are certain miscellaneous obsessions like need to know or remember, fear of saying certain things, not saying certain things just right, intrusive images, intrusive sounds, words, music, hoarding or collecting obsessions, blasphemous obsessions. Blasphemous obsessions, I've told you, they are the obsessions of blurting out obscene words in front of God or mandir or whatever the religious place may be. Obsessions के साथ usually accompanying होता है compulsions. Compulsion, the short-term role of compulsion is to reduce anxiety, but actually do they reduce anxiety? No, they don't. They just propagate the obsession cycle which I've just shown you. So there is excessive or ritualized hand washing, excessive ritualized bathing, brushing, grooming. Ritualized, say, I've used the words ritualized here because the patient usually have a very personal and a complicated style of washing hands. Washing hands will not be like a normal 15-20 second routines that we do. It will involve a very specific routine, like some I'll give you an example. Somebody says that, okay, I have to rub the soap in a certain way, then rub my hands in a certain way, then rub my elbows in a certain way. This has to be repeated in first my left hand and then my right hand. And if case my routine is disrupted, I have to go through the whole cycle again. Obsessions can involve cleaning household items, inanimate objects, other measures to prevent contact with contaminants. So there was once a patient who kept sitting on bed. His OCD became so severe that he was urinating and defecating in bed because he felt that the moment I keep my foot on the ground, I'll get dirty, and then again I have to start cleaning up the way I want it to clean up. So this is the kind of dysfunction that sometimes severe OCD patients may have. Then they'll be checking compulsions. Okay, so this kind of hand washing, again, please do not confuse it with the hand washing we do it nowadays with COVID, because This is what we do now with COVID. Washing hands every 1 hour is a ego syntonic. We know we have to do it, but when it becomes ego dystonic, that means I know it is irrational, I know it is not wanted, still I'm doing it again and again. That is when it becomes a problem. So checking compulsions, they can be checking that did or did not harm others, checking that did not harm self, checking for contaminants, checking that nothing terrible has happened or will happen. Then there'll be counting compulsions. Patients would like to count everything, keep it in a particular manner. Recounting happens, which again leads to a lot of time. Then there'll be repeating rituals, repeating a particular motor activity in a particular way for a particular number of time. Ordering or arranging compulsions, mental rituals. Mental ritual means it can be counting backwards, saying some mantra for if any obsessive thoughts comes, need to tell, ask or confess, need to touch. So see, understand most of the compulsions are in response to some or the other obsession. Okay, let us talk about the etiology and pathophysiology. Let us first talk about neurobiological factors. Here you have to understand three brain parts which are very important. You have the prefrontal cortex, the striatum, and the thalamus. These three are the most important for obsessive compulsive disorder. See, the frontal and the prefrontal, one has to understand, is most developed in human beings. Okay, so what does this prefrontal and the frontal cortices are doing? So the frontal lobe is responsible for error detection, working memory, goal directed behavior, and this sends a signal through the striatum. Striatum either passes the signal or it puts a brake, inhibits it. Any feedback which is coming, striatum will inhibit. Suppose there's an inhibitory feedback, so it will inhibit it. Otherwise, it will let it pass. And thalamus, which in part controls subconscious movements, receives signals from striatum, sends it back to the frontal lobe. And if the signal is too loud, it can disrupt activity there. So in this loop, there is a dysfunction which is happening. We call it the cortico-striato-thalamus loop. The feedback here is the inhibitory feedback somehow is lost, and so the loop keeps on going again and again and again. We call it a CSTC, cortico-striato-thalamocortical loop. Okay, one has to understand that it is these orbitofrontal and the striatal projections that are involved in adapting behavior to changing external demands, internal emotional stress, and this is the core problem in OCD. See, whenever the brain often, suppose a thought is generated in a brain, the brain either considers that thought to be logical and yes, leads to action, or there is a negative feedback which tells the brain, no, this thought should be stopped now, it does not serve any purpose. This is the inhibitory function also which the brain does, but this inhibitory function is somehow disrupted here, and the OCD cycle we discussed goes on and on. Genetic studies, yes, if the prevalency in normal population, the prevalence is around 1 to 2%, but yes, if the first generation family members, the first degree relatives we call it, mother, father, or any of the first degree relatives suffers from OCD, yes, then the chances of the family member having OCD becomes 10%. Now if you say a 1% or 10% में क्या difference है, ज़्यादा difference नहीं है, actually it is a 10 times increase. So yes, having a first degree relative definitely puts you at a higher chance of developing OCD. And studies have found that concordance rates of more than 30-60% is seen in monozygotic twins. See, the concordance rate is not 100%, which means that there are factors other than the genetic factors also. Usually the genetic transmission is multifocal transmission, hence a single gene till date has not been identified. So now we have something called learning theories also. See, let us read it first. Compulsion reduces the tension learned behavior. Compulsion reduces tension. The learned behavior becomes reinforced and eventually fixed. Compulsion in turn reinforces anxiety as they prevent habituation. So now as we go further, we'll read what is habituation. The contact with the fear-provoking stimulus dirt is not maintained, and habituation is a decrease in fear-associated stimulus does not occur. So what is happening here? The compulsion is leading to, the short-term goal of the compulsion was to reduce anxiety. But what is happening? The person is not facing the anxiety. Then this compulsion induced behavior is becoming reinforced and eventually it becomes fixed. This is one of the learning theories. And the therapy, the CBT therapy that is based on for OCD is based on this learning theory. So treatment. It's a very important MCQ that comes. What is the treatment of choice for OCD? Definitely the answer is SSRI, that is selective serotonin reuptake inhibitors. The confusing part is they also write clomipramine. Clomipramine is a TCA, that is a tricyclic anticholinergic. See, if you see head-on trials of an SSRI with clomipramine, they actually have similar efficacy. That means efficacy-wise, they are not different. The only difference comes in the tolerability, which is due to the lesser side effects of SSRIs. So the answer to this MCQ is always without a doubt will be an SSRI. But the doses that we use for SSRIs are higher doses than what we use for depression. Time for action is about 10 to 12 weeks. It takes usually, say for depression, if you give SSRIs, the improvement is seen within 4 to 6 weeks. But here the improvement takes a lot of time. Say it takes at least 3 to 4 months for the person to show improvement. And again, coming back to clomipramine, the efficacy, it is as efficacious as an SSRI, but definitely the side effects are more. The anticholinergic side effects can become very troublesome for the patient, especially because you are giving these drugs in a higher doses, on the higher side of the range. Okay, let's come to behavior therapy. Exposure and response prevention. This is the name of the behavior therapy that we are using. What we do is patient is asked to endure in a graduated manner the anxiety associated with specific obsessional fear provokes while refraining from the compulsions that allay the anxiety. So again, what is the principle? Compulsions relieve anxiety. Short term we have seen. This is a short term solution. Anxiety returns requiring performance of another compulsion. So once the patient who has the obsessive doubt of contamination, the moment he feels I have touched this doorknob, ye ganda hai, now I have to go and wash my hands. The moment he has this thought, oh, this doorknob I've touched is dirty, he will have a severe anxiety. Then he goes, washes his hand. Temporarily, what happens? For a few seconds, maybe a few minutes, the anxiety goes down. But again, the the obsession comes back again, and again the whole thing of washing hands happens. So the principle is habituation, resist anxiety, urge to ritualize anxiety. Anxiety eventually reduces on its own. This is called habituation. Looks easy, but sometimes very difficult to do in patients. So what do? We ask them to make a list of all those thoughts, and then we start with the least anxiety provoking thought. For example, the person will have thought of, say, let's start with the example I gave you: anxiety on touching the doorknob, anxiety on touching the remote, anxiety on touching the bed, anxiety on touching, say, pen. So we asked him, so we asked that person to make a list. Let us start with the lowest on the list. So suppose if the person says the lowest or least of them is, say, touching the doorknob. So during therapy and the post therapy, you ask the person to touch the doorknob. And then you tell him that this anxiety in that session, the 30-40 minute session that you have, you tell him that the anxiety eventually reduces on its own. The person observes that and he is able to then practice that on its own. And then we go on to the more higher anxiety provoking situations. Why we choose the lesser anxiety provoking situations? Because we want that person to get mastery over one, and then which improves his confidence, makes him believe that yes, he can tackle this anxiety. And then we go on to the higher anxiety producing elements. Okay, so now let us see a case. Miss S is a married woman in her late 20s who presented with obsessions, contamination obsessions. She washed her hand more than 100 times a day, checked items repeatedly for contamination, sought reassurance from others, also more than 50 times per day. She also had obsessions that if she did not do certain things, harm would come to her family. Her symptoms dated to when she was 13 years old, and when she started having thoughts that to prevent bad things from happening to others, she had to open and close refrigerators in a certain way. She had to close the lid of bottles in certain ways. Then she had to touch her eyes. She kept most of these rituals hidden from people. Her condition worsened during pregnancy. She avoided contact with family members whom she thought would be contaminated. She stopped doing household work. So, see the amount of dysfunction and the distress that the person is facing for n number of years. Okay, so what do you think should be the treatment? She was started on clomipramine, gradually increasing from 50, then gradually increasing to the maximum tolerable dose. Behavior therapy was started. Uh, she was asked to keep a daily record of her washing hands. Subsequent sessions, therapist asked her to touch knobs, shoes, continuously reassuring and pushing her to understand that if she would avoid or wash, she could easily come in command if she did not challenge these feelings. Her husband was made co-therapist in subsequent sessions. Subsequent sessions set more challenging goals, and after 18 months of treatment, she was able to cook meals, go grocery shopping, was able to have guests over her house. Okay, please keep parking questions, and after one more case, I'll take the questions midway. Okay. Okay, I think I have a lot of questions. So one more session, and then we'll start. Okay. Okay, so case 2. Mrs. M is a 38-year-old married school teacher who had experienced OCD symptoms in the age of 10. At that time, she had to reread sentences in her book, check doors, faucets to guard against something bad happening. Her symptoms subsided during teenage but then resurfaced again in her 20s. In particular, she had trouble driving the car. She found herself retracing her route to ascertain that she did not hit something. This lengthened her drive. She avoided driving and she asked her husband to drive and also asked him to go back to ensure that nothing went wrong. She also experienced repetitive checking behavior, like rechecking if she has written a check correctly or not, retracing her steps back in school to check if if she has hit something on the staircase. Overall, her symptoms were moderately severe, taking about a few hours per day. Gradually, she also started experiencing pervasive sad mood, early morning awakening, loss of energy, loss of appetite, weight loss. What is the diagnosis? What are the possible modalities of treatment? So, if you want, you park your questions. So, let me take the questions one by one. Ma'am, how is OCD? What is this? OCD consisting of something bad might happen. Differ. Okay, एक second. I cannot read this. Okay, just a second. How is OCD consisting of something bad might happen different from anxiety? Okay, something. See these the ones that I've just told you and I've shown you in the cases also. They are usually happening. These are the usual obsessive symptoms which are seen in children. Children, when they develop OCD, this is the kind of symptoms that is seen. So in this, there is just one thought: something bad may happen to my family members, something bad may happen to my mother. So I'll give you an example. There was a child who used to come to me who said, "जो carpet के end में tassels होते हैं ना, जो एक धागे निकल रहे होते हैं," she said, "that have to be perfectly straight. Otherwise, I have this fear that my father, whenever he goes to the next meeting, he will die in that meeting." So these are the kind of obsessions sometimes children have. Okay, so this is different from generalized anxiety. Generalized anxiety we covered last time. This is anxiety. नाम है उसका generalized anxiety because it is generally happening in every sphere of life. It is not just one thing, something bad may happen. Generalized anxiety will be something like, how will I do my exams? Okay, how will I go out and make friends? how it is happening about everything in life. All right. If you want any further clarifications also, you can. Okay, please explain checking compulsions. Checking compulsions will be something like um, you leave the house and you have this thought कि मैंने गीजर बंद किया या नहीं, ये डाउट है, ये है ऑब्सेशन. आप क्या करोगे? वापस जाओगे, एक बार एक चक्कर लगाओगे, and then you'll close the geyser and come back. A person who has OCD will close the geyser, come back, again go back, again check, again go back. Probably again the doubt will surface. शायद मैंने ठीक से नहीं देखा. वापस again go back. Again this sleep keeps on repeating. Like the cases also I've told you, there are people who check 100 times, who wash their hand 100 times. So imagine the amount of time taken and the amount of distress that the person is facing. So this is checking compulsion. It could be anything. I have given you an example of switch. It could be checking the money in your wallet. It could be checking what are the things in your bag. It could be checking anything. It could be checking switches. Okay, let me take the next question. You want the learning theory again. So see, the learning theory is the theory on which we are basing our ERP. Okay, that is the ERP. So let us see. Compulsions, learning theory says that compulsions relieve anxiety. So what happens? The person naturally learns that jahan mujhe ye thought aaya, doing that compulsion will relieve my anxiety. But that person does not know that anxiety relief is only temporary. The obsessions will keep coming back. Okay. On the other hand, controlling yourself on doing the compulsions, anxiety eventually reduces, which is called habituation. Okay, I think this is enough for you to learn learning theory. If you know this much, I think it's enough. What is magical thinking? Magical thinking, again, seen in children. If I don't do this, something bad will happen to my family. Or say example, thoughts leading to action is something which is called magical thinking. Like if I urinate in a particular way, this whole the world is going to be flooded. So this is what is magical thinking, usually seen in childhood obsessions. Is that the last question? Okay, no. Why worsen during pregnancy? See, a number of psychiatric illnesses worsen during pregnancy. So exact cause not known. It could be because of the stress associated with pregnancy. It could be because of the hormonal changes associated with pregnancy. But a number of psychiatric illnesses worsen with pregnancy. In addition to pregnancy having its own problems, it is seen that not in all cases, but yes, in a lot of cases it is seen. Okay, is this a real case? So this case is taken from a book, but in reality also these cases are very much seen in the OPD. Ma'am, why is SSRI not used in case 1 despite of clomipramine? Okay, again, as I've told you, SSRI, clomipramine have a similar efficacy. Why we choose a particular drug in the OPD has a lot of factors. See, we have to see the side effect profile. The clinician who is sitting there has their own experience. Then I have to see which is more commonly available in my in my pharmacy or the just pharmacy outside my hospital. So my hospital, SSRIs are given for free. So I most commonly give SSRIs. So again, it is said that they have equal efficacy. ऐसा नहीं है कि fluoxetine is better than clomipramine in terms of its efficacy. दोनों equally act करती हैं. Only side effect profile is different. If your patient is tolerating clomipramine, you can even give clomipramine. How do we grade symptoms as mild, moderate, severe? See, there are rating scales that we are using for number of psychiatric conditions. For OCD, we use Y-box rating scale. Plus, there is always a clinical judgment also. If my clinical judgment is that patient has severe OCD, then I treat it like a case of severe OCD. Okay, ego dystonic versus ego syntonic. Ego dystonic means ego syntonic is what is consistent with syntonicity से आप समझो syntonia और dystonia समझो पहले. Syntonic means it is very much in lieu with my thoughts. Nowadays, if you are washing hands happily every 1 hour, this is not OCD, because you know that the only way I can prevent infections or cross infection is probably by washing my hands. But if you ego dystoning means I don't want this thought to come. This thought is repeatedly coming again and again, and I am very disturbed by these thoughts. This is ego dystonic. Why is sad mood in the case 2? Okay, this is something you have to tell me, that why sad mood is there in in this. See, the person is having so much distress. He or she is not able to do whatever they are supposed to do. So having depression, this case I especially included because she, along with OCD, she is even having depression. So OCD and depression many a times go hand in hand. It's not that they will always occur, but yes, in many cases, especially in the severe, moderate to severe ones, you will see them depressed also. OCD complicating into depression is the diagnosis here. Yes, very good. OCD with depression will be the diagnosis. OCD has own thoughts and they are intrusive. What does this mean? So this we are doing it to clarify it from psychosis. In psychosis, in schizophrenia, person will say that somebody has transplanted its thoughts into me. But the OCD person knows that they are not somebody else's thought. They are my very own thoughts. At the same time, they are intrusive, that I don't want them to come, but they are repeatedly coming into my territory. That is what is intrusive. Recognizing thoughts as my own is specially done to differentiate it from psychosis. Can behavior therapy alone help with anxiety? In mild cases, yes, but if it goes beyond mild, then probably no. Then you need a combination of both the medication as well as behavior therapy. Actually, obsession is a disorder of content of thought or possession of thought. Very good. Who has asked this question? This is actually a PG level question. It is actually a disorder of possession of thought. Difference between OCD and anancastic personality disorders. Anancastic personality disorder, also known as OCPD, obsessive compulsive personality disorders, उसमें ये होता है that a person have their own rigid rules by which they do work. And again, this is not ego dystonic. The patient doesn't get disturbed. People around them get disturbed, but for them, this is the way of life. This is what their personality is. OCD patients are aware of the situation. Yes, they are aware of the situation. That is why they have distress. Okay, that is why they have anxiety. That is why they have distress. They are pretty much aware that these thoughts are senseless. That is why they have. But what happens is, although they are aware of the situation, they do not perceive this as maybe a mental illness. That is why it is said that sometimes patient who is coming to your clinic comes after 10 years of suffering from OCD. It is seen many a times. Time lag between starting of symptoms and taking treatment. They may not they may not be aware that it's a mental illness that can be improved with treatment. Okay. Somebody wants to see case study 2. Okay, I've put case study 2. Magical thinking different from delusion. Like both can thinking something unrelated can happen. So again, delusion is a firm, fixed, false belief. Okay, and magical thinking is something, again, I would repeatedly say, is seen in children. What is magic? That if I think, pigeon will appear. Okay, so such kind of thinking is seen in children. And delusion will be a fixed, firm, false belief, and magical thinking again will be patient will have insight that no, what I'm thinking is probably senseless. it does not have so much sense. Delusion patient will never say that what I'm thinking is not right. If the delusion patient thinks that yes, the president of America wants to kill me, for him it is the most correct thing that is happening in his world. Are tricyclic antidepressants safe in pregnancy? Hi, no, they are not safe in pregnancy. They lead to congenital malformations. SSRIs are the safest in pregnancy. Again, one more reason to prefer SSRIs. Okay, yes, high dose related side effects are the the anticholinergic side effects, constipation, hypotension. Can compulsions be without obsession? Unlikely, very rarely, very, very rarely. Doing something in a certain way without having reason behind it, no, then they will not be called a compulsion as in OCD. Okay. What happens if we do not give reassurance to a person with OCD? So see, in therapy, we have to give reassurance that the anxiety will reduce even if you don't do the compulsion. So आपको compulsion और obsession को अलग करना है. That is what you are doing in a therapy. So the person learns that compulsion is actually reinforcing the obsessive doubt. It is reinforcing the thought. It is not helping. Okay, so we have to give reassurance that the anxiety is going to come down even if you don't perform the compulsion. Is the treatment lifelong? See, as I have told you, that it is a condition is chronic with a waxing waning course. That means there will be periods when the OCD is down, there will be periods when it is up, stress related periods when the symptoms may increase. So the treatment, the protocol, again depends on patient to patient. Every case is different. Somebody who has an OCD starting from say 12 years of age, yes, for them the treatment can be lifelong, but yes, during periods of remission you can bring down the doses, but usually treatment is given for a long time. Delusion is rigid even after proof against that thought is given. Yes, very correct. That is what his delusion is. Is magical thinking real issue for a child? Does it need to be treated? No, see, if only magical thinking, children are supposed to think magically, it's fine. But it becomes a disease when the child is repeatedly thinking about it, performing compulsions, which are again dysfunctional, then it becomes a disease. So you have to see every patient in its difference. Children are supposed to think magically, that's fine. Okay, so now case 2 also done. We'll move ahead. What is the diagnosis? Diagnosis is OCD with depression. Possible modalities of treatment would be start on selective serotonin reuptake inhibitors. Okay, and among the selective serotonin reuptake inhibitors, all are again equally efficacious. Fluoxetine and fluoxamine are said to be are said to work best, but if you see scientific data, even paroxetine, sertraline are working pretty well for obsessions. Okay, so now we have introduced this term called obsessive-compulsive spectrum disorders. तो ये concept of spectrum disorders आप psychiatry में ही देखोगे. You will not see in medicine and surgery. You will not have an inguinal hernia spectrum condition. So the 4-5 disorders that I discussed initially. What are they? They are disorders that share feature with OCD. Similarities are there with OCD across multiple domains like symptoms, treatment response, comorbidity, joint familial loading, and course. They may not be totally identical, but these are the similarities seen. So in psychiatry, you have obsessive compulsive spectrum disorders, then you have autism spectrum disorders. This is just an example that I'm giving you. So this is the spectrum concept that you see, especially in psychiatry, okay? OCD, body dysmorphic disorders, hypochondriasis, trichotillomania, hoarding. This is something you see. They have symptoms similar to OCD. Okay, body dysmorphic disorder. It is said that Michael Jackson probably had body dysmorphic disorders. We don't know for sure, but this is what a lot of scientists had said. There is preoccupation with one or more perceived defects or flaws in the appearance which they believe look unattractive, deformed, or abnormal. Perceived flaws are not observable or only slightly in other individuals. Usually, these people go to plastic surgeons and physicians before ever landing up to psychiatry. Sometimes they don't land up in psychiatry also. Preoccupations can focus on one or many body areas: skin, hair, nose, stomach, breast, face size, shape. Preoccupations are intrusive, time consuming, again, like OCD, maybe 3 to 8 hours, unwanted, difficult to resist or control. Excessive repetitive behaviors, repeatedly checking defects in the mirror, excessive grooming, camouflaging, seeking reassurance, seeking cosmetic procedures, or mental acts could be comparing. So that is why this disorder was initially kept with somatoform disorders, but now in the new classification, this is being classified with OCD. Associated features: insight is poor. Insight means awareness that they have a problem. High levels of anxiety, social anxiety, low self-esteem. Dermatology treatment and plastic surgery is common. Usually chronic, waxing waning course. Sometimes they do achieve remission also. Again, 1 to 2%. Onset is usually adolescence. Rate of suicide is very high in such adolescents. Again, treatment: SSRI, doses used in OCD, doses used for OCD, which are definitely the higher side of the dose range. Okay, so let's see another case scenario. Miss R, a 22-year-old college student living with her parents, was referred to psychiatry due to preoccupation of 4 years that something is wrong in the way her teeth are situated in her jaw. She would not specify what exactly was wrong, but insisted that she felt funny at times and would actually relocate, especially during eating food. She spent hours each day in front of the mirror examining her teeth from various angles. She would repeatedly ask people their opinion as to whether her teeth were abnormally placed. She has already received multiple dental, orthodontic, oral surgery evaluations which did not detect any abnormalities. So see, this person usually does not go to the psychiatrist first, they go to the other physicians first. Then there's something called hoarding disorder, in which the patient is, hoarding items which are not of use. As Indians, we always have a storeroom in the house in which we keep stuff we feel that yes, we will use it next time. You will often say your mummy say, papa say, rakh do, kaam aa jayega. But most of them are items which actually you do get to use, right? So once I had a patient who was collecting जो मदर डेयरी की दूध की जो pouches आते हैं, she used to keep that stored in her house, and gradually it happens that gradually the whole house gets filled with such unnecessary items. So virtually any items can be saved. Experience distress when faced a prospect of disregarding them. Items fill up clutter active area. When the items that you are saving starts coming from the storeroom to your living room, then it means becomes a problem. Trichotillomania or hair pulling disorder, recurrent pulling of one's own hair resulting in hair loss. Most common sites are scalp, eyebrows, eyelids. Less common are axillary, facial, pubic, peridactyl regions. Sites may vary across time. Attempts to conceal or camouflage hair loss with scarf, makeup, accompanied by a range of behaviors or rituals involving hair pulling in a specific manner, sometimes even swallowing. Again, an MCQ here, which is called trichobezoars. A hair pulling may be preceded or accompanied by various emotional states like increasing sense of tension, gratification, pleasure, and a relief when the hair is pulled. Hair pulling behaviors involves various degrees of conscious awareness, some displaying focused attention on hair pulling, others displaying automatic behaviors. So there will be a mixture of various styles. Again, 1 to 2% females outweigh the males in these disorders. High rate of mood disorders and anxiety disorders. Comorbidity. Usual course is chronic with waxing waning course if the disorder is untreated. Again, let us see a case. A 32-year-old male began pulling hair in his second year of college. He had always been an anxious person and thought of it initially as a nervous habit. He noted his hair pulling tended to be worst in stressful situations like before exams, after a breakup with a girlfriend, or when he was studying. Sometimes he was hardly even aware of it, and he would find his hands roaming around in his scalp and pulling the hair. He was commented upon appearance of his hair, but he did not care much about it. Gradually, this increased, and he was pulling from virtually every spot on his body where his hair grew, including the perineum. So this is a case of trichotillomania. Again, if you would like, please park your questions. I think this is the last slide. Yes. Einstein also had compulsion of non-stoppable imagination power in physics. This won't be this. Okay. So this would not be abnormal, right? He was bringing out a lot of new inventions and a lot of new study material. So this won't be abnormal. There is no dysfunction associated with it. There is no distress associated with it. Joint familial loading means cases occurring in a family. So this is something like that. Familial loading means cases occurring together in a family. Difference between OCD and obsessive compulsive personality disorder. Again, obsessive compulsive disorder, they will personality there. It is not ego dystonic. They are not distressed by these thoughts, and the amount of preoccupation is also not so high. Obsessive compulsive personality disorder is somebody who keeps their books in a particular order, who keeps their pens in a particular order. It is not ego dystonic to them. They like doing that. Although people around them may get fed up by their behavior, they usually like doing all that. Why are these disorders more prevalent in females? There is no particular answer for that. This is how it is found in epidemiological studies, but we actually don't know why they are more prevalent in the female population. Okay, any more questions? I cannot see any more questions. Any more questions? Please park it in this question box. Otherwise, we will. Thank you. Okay, thank you, ma'am. That means no more questions. Okay, it's 6 o'clock also. Thank you for being patient listeners. Thank you very much. Hope you enjoyed. In case you find it boring, you can always give that feedback also. Thank you.